Again, I'm going to talk about tailoring the blood glucose monitoring to the diabetic patient's needs. And let me start with the International Diabetes Federation 10th Atlas. Just these figures are declared few days ago. We are now having 537 million persons living with diabetes, and diabetes is spiraling out of control. 1 in each 10 adults is living with diabetes. Almost half of these diabetic persons are not controlled. According to the IDF, again, a rise of 16% happened between 2019 and 2021. And these are the 7 IDF regions. And let me concentrate on the Middle East and North African region, when we have 73 million persons living with diabetes. 10% of the adults are living with diabetes and they are undiagnosed. And by 2045, we're going to have 783 million adults living with diabetes, a huge increase in global prevalence. 4 out of 5 people with diabetes live in low and middle income countries. Diabetes hits the poorest hardest. And again, in key global findings, 2021 International Diabetes Federation, there was estimated 6.7 million deaths due to diabetes in 2021. And these figures didn't include the increased mortality risk associated with COVID-19. This figure is about 11.2% of global deaths from all causes, and there was increase in incidence of diabetes and increase in mortality during 2021, and this was explained by inefficient access to hospitals due to COVID, and maybe the use of glucocorticoids in COVID treatment increased the incidence. For 500, sorry, it's moving without 541 million adults, or 10% of adults worldwide, are having impaired glucose tolerance, so they are at risk of developing type 2 diabetes. Globally, 90% of people living with diabetes are having type 2 diabetes, and this is driven by the complex interplay of socioeconomic, demographic, environmental, and genetic factors. The key contributors include urbanization, aging population, decreasing level of physical activity, and increasing prevalence of overweight and obesity. Again, key findings from the 10th edition of IDF Diabetes Atlas. Diabetes was responsible for estimated $966 billion in global health expenditure in 2021. When we talk about our subject today, tailoring the blood glucose monitoring to the diabetic patient needs, this is my agenda. I'm going to talk about challenges, barriers, and unmet needs in diabetes management, the burden of diabetes to the individual, and role of digital health in enhancing care of people living with diabetes. Why do we need an aggressive treatment strategy? Because at diagnosis of type 2 diabetes, 50% of patients are already having complications, and up to 50% of beta cell function has already been lost. And in spite of the current management and advances in diabetes treatment, 2/3 of patients do not reach the target hemoglobin A1C, and the majority require polypharmacy. These are the diabetes complications according to IDF. Diabetic retinopathy affects 1/3 of all people living with diabetes, and it is the leading cause of vision loss in working age adults. People with diabetes are 2 to 3 times more likely to have cardiovascular disease, and the prevalence of end-stage renal disease is 10 times higher in people with diabetes, and every 30 seconds, a lower limb or a part of the lower limb is lost by amputation due to diabetes. And pregnant ladies and those ladies who are at high risk for gestational diabetes, they have offsprings with higher risk of obesity, diabetes, hypertension, and kidney disease later on in their life. Patients with diabetes often have multiple risk factors. 45% of them are obese, and 75 to 80% of them are having hypertension, and half of these patients are having hypercholesterolemia and sustained reduction in hemoglobin A1C, and maybe other parameters will benefit the health of patients with type 2 diabetes. According to the AGA 2021, diabetes was classified into 4 groups: type 1 diabetes due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency, including latent autoimmune diabetes of adulthood, and type 2 diabetes due to progressive loss of beta cell function and a background of insulin resistance. And there is a specific types of diabetes: monogenic diabetes syndrome, neonatal diabetes, and maturity onset diabetes of the young. Disease of the exocrine pancreas, like cystic fibrosis of the pancreas, pancreatitis, drug-induced, chemical-induced diabetes, for example, after glucocorticoid use, the treatment of HIV, or after organ transplantation. And the 4th type of diabetes, according to ADA classification 2021, is gestational diabetes, which is diagnosed to the first time during the 2nd or 3rd trimester of pregnancy. Let me now discuss the criteria for diagnosis of diabetes, and I'm sure all of you know these criteria. Fasting plasma glucose of 126 or more milligram per deciliter, and fasting is at least 8 hours with no calorie intake. 2 hours plasma glucose more than 200 milligram per deciliter, and A1C more than 6.5 or equal to 6.5, or if the patient is having classic symptoms of hyperglycemia or hyperglycemic crisis with random plasma glucose more than 200, then we can diagnose diabetes. And for hemoglobin A1C, and to avoid misdiagnosis or misdiagnosis, the A1C test should be performed using a method certified by the National Glycohemoglobin Standardization Program and standardized to the DCCT trial assay. In conditions associated with altered hemoglobin A1C, either causing higher or less than average hemoglobin A1C, this can occur in certain hemoglobinopathies like sickle cell disease, pregnancy, 2nd and 3rd trimester, and postpartum period, glucose 6-phosphate dehydrogenase deficiency, HIV, hemodialysis, recent blood loss, blood transfusion, or erythropoietin therapy. In these conditions, we cannot depend on hemoglobin A1C either for diagnosis or for follow-up of the patients. So according to AGA, only plasma blood glucose criteria could be used either to diagnose diabetes or to follow up diabetes. And there is importance of tight glycemic control, and this was shown in UKPGS, where tight glycemic control caused any diabetes-related endpoints to be less by 12%. There was reduction in microvascular complications, 25%, reduction in myocardial infarction, 16%, in retinopathy, 21%, and albuminuria, 34%. This was done by intensive glycemic control with reduction in other risk factors for type 2 diabetes-related complications. And despite the potential of insulin therapy in this figure by the National Health and Nutrition Examination Survey, more than 50% of type 1 and type 2 diabetes were not at the goal of less than 7%. Again, in patients with type 2 diabetes, 50 to 70% of these patients fail to achieve hemoglobin A1C target of less than 7% 1 year after insulin therapy. And in type 1 diabetic patient in this study done by Miller et al. And published in Diabetes Care, type 1 diabetic patients' hemoglobin A1C remained above target in different age groups. Again, in the same study done by Miller et al., the majority of type 1 diabetic patients did not achieve the glycemic target. Whether the target was less than 7.5 in patients less than 17 years or below 7% in patients above 18 years. Fear of hypoglycemia is one of the major concerns leading to failure of glycemic target achievement, and there was physician concern and patient concern. And the most important concerns were fear of hypoglycemia, impact on social life, and cost issue. These are the pathophysiological cardiovascular consequences of hypoglycemia, and hypoglycemia is a serious complication of diabetes treatment or some of the diabetes treatments, whether insulin or some oral anti-diabetic medications. Hypoglycemia leads to increased inflammation, increased C-reactive protein, increased interleukin-6, endothelial dysfunction, hemodynamic changes, increased adrenaline, increased contractility, increased oxygen consumption, and heart workload. There is rhythm abnormalities with hypoglycemia. And there is hypoglycemia effects on ECG, and it caused ECG abnormalities. Abnormalities in atrioventricular conduction, in ventricular depolarization, repolarization, and T-wave flattening and prolonged QT interval, leading to possible arrhythmias. And this study, done on 860,000 patients, showed that patients with hypoglycemic event had 79% higher odds of acute cardiovascular events than patients without hypoglycemia. Back again to glycemic goals of the AGA 2021, and hemoglobin A1C goal of for adults of less than 7% without significant hypoglycemia. This is the goal for most of the diabetic patients. And if we are using ambulatory glucose profile or glucose management indicator to assess glycemia, a time in range of more than 70 with time below range less than 4% is accepted. The achievement of lower hemoglobin A1C than 7% may be beneficial if the patients can reach this goal safely without hypoglycemia. Less strict hemoglobin A1C goal, such as less than 8%, is appropriate for patients with limited life expectancy, patients with renal, hepatic, or cardiac comorbidities. Again, this is a summary of the glycemic recommendation ADA 2021. Hemoglobin A1C should be less than 7%, and the preprandial capillary plasma glucose between 80 and 130 milligram per deciliter, and the peak postprandial capillary plasma glucose less than 180 milligram per deciliter. The time in range is a definition cropped recently, and it is associated with the risk of microvascular complications, should be an acceptable endpoint for clinical trials. moving forward and can be used to assess the glycemic control. Professor Nancy just mentioned this slide. The time in range, according to ADA 2021, between 70 to 180 should be greater than 70% of the daily hours, almost 16 hours and 48 minutes. Below 70 milligram per deciliter, less than 4% of the day. Below 54 milligram per deciliter, less than 1% of the day, 14 minutes. Above 180 milligram per deciliter, less than 25, which is equal to 6 hours per day. Above 250, less than 5%, 1 hour, 12 minutes. I come now to Diabetes Canada 2018 about monitoring and the glycemic control and SMBG, accompanied by a structured education program, should be done to all diabetic patients to facilitate the behavior change, resulting in improved outcomes. And to individualize the frequency of SMBG according to the individual condition and according to the anti-diabetic medication, and to teach the patients how and when to perform SMBG, how to record the results, meaning of various blood glucose levels, and how behavior and actions can affect SMBG results. The key messages from Diabetes Canada: the timing and frequency of SMBG is determined based on type of diabetes, type of anti-hyperglycemic treatment, the need for information about blood glucose level, and the individual capacity to use this information to improve his self-adjustment, to improve his healthy behavior and lifestyle. And these were the recommendations for most individuals with diabetes. A1C should be measured every 3 months to ensure reaching the glycemic goals. And in some circumstances, like change in therapy or during pregnancy, it's appropriate to do more frequent hemoglobin A1C. And we can test every 6 months in those patients with stable hemoglobin A1C reaching the target and stable treatment for diabetes. Again, recommendation for individual using insulin more than once per day. SMBG should be used as an essential part for diabetes self-management. Should be taken at least 3 times per day and including pre and postprandial measurement. For type 2 diabetic patient on once daily insulin with a non-insulin anti-hyperglycemic agent, to test at least once per day at variable times. For individual with type 2 diabetes not receiving insulin therapy, the frequency of SMBG should be individualized according to the type of anti-hyperglycemic agent, whether this agent is causing hypoglycemia or non-hypoglycemic anti-diabetic medication, and the level of glycemic control and the risk of hypoglycemia. If achieving glycemic target, then we can lessen the frequency of SMBG. For individual with type 2 diabetes, in people with type 1 diabetes who have not achieved glycemic target, real-time CGM may be offered to improve glycemic control, to reduce the duration of hypoglycemia in individuals who are willing to use these devices. Flash glucose monitoring may be offered for people with diabetes to decrease the time spent in hypoglycemia. And in order to ensure accuracy of blood glucose meter readings, meter should be compared with laboratory measurement. We can test by the glucometer the home glucometer together with the laboratory, either fasting plasma glucose or at least annually when hemoglobin A1C does not match the glucose meter readings. In individuals with type 1 diabetes, they should be instructed to perform ketone testing when the blood glucose is above 250. For CGM, we have two types, real-time or personal, continuous blood glucose levels, blinded or professional. Capturing blood glucose level can be downloaded later, and real-time CGM has been shown to reduce hemoglobin A1C and to reduce time spent in hypoglycemia. The successful use of CGM is dependent on adherence with duration of time used. The flash glucose monitor measures plasma glucose in interstitial fluid, and the blood glucose value displayed when sensor is flashed with a reader device on demand, and it displays plot profile of at least 8 hours, and sensor can be worn for 14 days, and it has been shown to decrease time spent in hypoglycemia in type 1 and type 2 diabetes. And let me end with this glucometer, which is a smart meter. The simple smart meter tailored to different patient needs. It is simple to help patients to test with confidence, and informative, providing patients with instant feedback about their blood glucose and the risk of hyperglycemia or hypoglycemia, and it is remarkably accurate. The smart light, either a green light, which shows that the patient is in target, and if it is yellow color, then the patient knows that he's above target, and if below target, the patient is going to have the red color or see the red color. This is the new advances, and let me thank you.